that supply blood to the heart muscle. The same way there are arteries supplying blood towards your head, up towards your brain. Cholesterol plaque builds up on the inside of arteries for everybody. From your teenage years, it starts to build. When you're very, very young, you're less than 12 years old, your cholesterol's super low. Modern lifestyle and our genetics have changed things such that your cholesterol is always going to go up and up and up as you age. And as you age, this yellow stuff here, this cholesterol builds up on the inside of the arteries. Worst case scenario of a block here, worst thing that can happen is a heart attack, and this heart muscle becomes damaged. Worst case, if it goes up towards your head, it's a brain attack or stroke. So this is what we're trying to prevent. Cardiovascular disease. Cardio, heart, vascular, vessel, they're all one big family. And the way to treat it, the way to prevent it, it's all the same. And all the causes are the same as well. Cholesterol deposition in the arteries, causing blockages, preventing blood flow to whichever organ it supplies. So this is what we're trying to prevent, a heart attack. And 80% of sudden cardiac death, people collapsing, 80% of it is due to this. So what are the risk factors for heart disease? Okay? You've heard about this many, many times. People have told you don't smoke, don't drink too much, don't eat too much fatty food. Fair enough, but lifestyle accounts for only part of it. There's a whole list of other things. So of course, as we said, smoking, diabetes. Diabetes is not from eating too much sugar. Actually, diabetes is an autoimmune condition. Your body cannot process the sugar. There are people who drink 10 cans of Coke a day and don't get diabetes. And there are people who watch their diet every single day and they get diabetes. It's an autoimmune condition, something that exists within your body. Obesity, overweight, high blood pressure, high cholesterol, not active enough. Genetics play the biggest part of all. Your genes are the biggest thing, the one thing that you cannot change. Of course, stress. Stress occurs in all of life. And something that's not very well recognized, but obstructive sleep apnea. Okay? Obstructive sleep apnea is when your airway is blocked when you breathe at night. I'm sure, I'm not going to ask you to put up hands, but I can guarantee you 20-25% of people here snore. You're snoring because your airway is obstructed, you put stress on your heart, and that is a risk factor for heart disease that is not recognized and very often not screened or tested for. Okay? So, among all of these, of course, smoking, easy, you can stop. But high cholesterol, there's always a lot of misinformation about cholesterol. People say, oh, cholesterol is fine, it doesn't matter. Cholesterol is the one thing you can change, the one thing that you can reduce the most with medication and lifestyle that can change your risk and reduce the risk of a heart attack by more than 50%. Hyperlipidemia is the other word for high cholesterol. And if you look at this, we have Singapore guidelines where you say less than 130 is okay. That is okay for an unhealthy human population. But if you think and you go back to this, animals and children, their cholesterol is less than 50. These are the numbers that you see on a sheet of paper when you go into a blood test anywhere, at your GP clinic, your polyclinic, at your specialist clinic. And they'll come in with a range like this. Less than 130 for the LDL, which is the bad cholesterol, is okay. In truth, it is okay in general, but you should try to get it lower and lower. And if you have blocks in your heart arteries, what you need to do is get that bad cholesterol LDL as low as possible. A lot of people look at the total cholesterol. The total cholesterol in that list is not as important as the most important thing called the bad cholesterol that causes the heart attacks. Clear so far? Everyone clear so far? Yeah? Okay? We have HDL, the good cholesterol. They say if you bring your HDL up, you reduce your risk. HDL being high is good, but it doesn't undo the risk caused by the bad cholesterol. That's something to remember as well. That's why we put a lot of patients, no matter what their HDL is, if their LDL or bad cholesterol is high, we put them on medication to reduce their risk. Okay, so remember this. When you were very young, below 12 years of age, your LDL was probably 50. That is what we aim for people with heart disease when we put them on medication. Okay, so a little bit of an explanation as we go through, just to understand the basics. I hope you're okay. And the most important thing, a lot of people feel that, okay, my cholesterol's high, I just cut down my diet, everything is going to be okay. Only 25% of your cholesterol comes from food. The other 75% is your body in itself, is your genetics. And if it's super high, no matter how much you diet, the most you can reduce it is 10%. No matter how much you exercise, the most you can reduce it is 10%. I'm not saying don't do it, I'm saying do it, please, as much as you can. But if your cholesterol is super high and your doctor's put you on meds, please take it, because that's going to reduce your risk more than 50%. Okay? Because all your cholesterol, most of it, 75%, is produced by your liver and is part of your genetics. Okay? Now, the other day I had a lady who walked into my clinic, and for years on end, okay, she's an Indian lady, she said she had these exotic eyes where she's got a rim of white around the eye for years on end. Okay? Her cholesterol, her LDL, remember I told you less than 130 is what we look for, less than 70 is what we look for people with blocks. Hers was 200. And what happened is her cholesterol built around the eye in that area. And for years everybody thought she was mixed blood, exotic, looking good, but she came in with loads of blocks in her heart arteries that we need to fix. So these are the small things that we can look out for. I've had a 9-year-old girl with cholesterol, familial, meaning it's genetic. She had cholesterol plaque built up on her hands like this. We've had to put her on medication as well. Okay? So it's something for you all to look out for. But the most common thing that many people see is a little collection like this above the eye. And that is a cholesterol deposit. Many people go and see plastic surgeons or aesthetic doctors, have it lasered, and what they don't realize is the reason that is deposited there is the same reason that cholesterol deposits in your heart arteries. It is cholesterol deposit in the skin. Just to show you a few examples, then I'm going to show you some other stuff as we go along. Okay? So the most important thing I'm trying to tell you from all this is, if your doctor has put you on a cholesterol tablet, there's usually a very good reason. Don't stop it. Stopping it increases your risk. Many people think cholesterol tablets are poison. They are not. They are going to reduce your risk of getting a heart attack by more than 50%. Okay? This is from the Straits Times and Channel News Asia. There's lots of articles in the newspapers recently trying to educate the public. Okay, so I mentioned the cholesterol levels. I'm going to do all boring stuff. After this is all pictures and videos, okay? I thought while you're awake, I'd try and show you all the data. So if you are a high-risk person with blocks, your LDL or cholesterol, a lot of you here would have done your blood tests. You will know a little bit about your numbers. These are the numbers we aim for. If you're low risk, less than 3, there are 2 scales, like a metric and a non-metric scale, 3 or 116 for those of you who know. I would suggest you take a picture of this for those of you who go and do a blood test, and you can compare it to your own blood test. If you're medium risk, it needs to be even lower. You're high risk, it needs to be even lower. And if you've had heart attacks, this is the current guideline. Less than 55 milligrams per deciliter, less than 1.4. I can guarantee that more than half of you have done blood tests somewhere by now and have had a look at it. So you will have an idea of what this is. And if people have multiple blocks, we go even lower. So when your doctor tells you your cholesterol needs to be even lower, don't look at what's written on that sheet of paper, which comes with it. That is for a normal population with no blocks. Your target is set by your doctor depending on what your heart condition is. Okay? So cholesterol, the most important, most modifiable risk factor. Okay? So, I mentioned that we live in a very modern age with a lot of modern technology. We've got a lot of state-of-the-art technology to diagnose, to figure out whether you've got blocks, what you need to do, what heart problem you have, how we can fix it. The most important thing is to go and see a doctor. What happens a lot nowadays is people go and do a health screen. They look at the result, they take it back with the printout, and they don't go and see a doctor to go through those results. And what they do is they manage it themselves without looking at it. Because you can do health screens nowadays without needing to go through it with a doctor. Or they'll postpone the appointment. So they don't get a clarification of what goes on. So the most important thing is to get examined, seen by somebody. We have a fantastic setup in Singapore where you've got access to healthcare wherever you want to. Polyclinics, GP clinics, specialist clinics, lots of these are available. And where you go depends on you and what you can afford to do. Unfortunately, sometimes, if there is a financial constraint, we still have the ability to get fully screened in the polyclinic setting as well. So the first thing people always do is an ECG. Okay, an ECG takes only a few minutes. You stick a bunch of leads around the heart, look at the electrical activity. It cannot tell you what your blocks look like, but it can give you a good idea of what's going on. From the ECG, we can do ultrasounds of the heart, which I'll show you, X-rays of the chest, and a lot of this is part of your national health screening program as well. And then if needed, a treadmill. A treadmill is basically an ECG while you're walking on a treadmill. For many people who they can't walk, they've got mobility issues, there are other tests that we can do as well. Among those tests are ultrasound scans, CT scans, and for those of you who've got blocks and need to get it fixed, of course, people like me will do something called an angiogram or angioplasty, and I'll show you that in a short while. Okay, but there are all these tests that can be done, and your doctor will decide which level you go and do and which level of tests you do, depending on how your risk is. Okay? I'm just showing you a few things. So if you do an ultrasound scan in your heart, okay, they call it Salmero, right? Okay? Ultrasound scan in your heart muscle. If you look, this patient here, these are 4 chambers of the heart. 1, 2, 3, 4. These are valves opening and closing. And you look at this one. This guy doesn't seem to be squeezing as well as this. So this person actually had a heart attack. That means the heart muscle has become weak. It doesn't pump as well. Okay? And that's why this particular person is breathless. You following me so far? Yeah? Everything okay? Okay. Right? So this is what we have. So good squeeze, poor squeeze. And if you can't see it so clearly, what you see is this. You see it doesn't squeeze my finger, it doesn't come in as much, whereas the other one does. Okay? So this is called an echo or an ultrasound scan of your heart, looking at heart muscle. It can tell you if you've got holes in your heart, valve problems, valves that need fixing. It's a simple test, no radiation, but it needs for you to sit somewhere for about half an hour for someone to scan it. The next scan I'm going to show you is a scan of the neck arteries. I told you that a block here can cause a brain attack or stroke. So if you look at this patient here, this is all of us when we were 20 years old. Nice, clean, no blocks. This is someone with blocks in the heart in the neck arteries. If these blocks get bigger and they reduce flow, you have a risk of getting a stroke. So this is some of the stuff that we do in our clinic. You can't get access to this anywhere at any health screening center, but certain specialist clinics and certain setups have the ability to do tests like this for you. So if you've got blocks here, then you probably have blocks here too. Because it's like the pipes in your house. After 50 years of age, we always use 50 as an analogy, the pipes in the house start having problems, the electrical wiring starts having problems, and if one pipe has a problem, usually another one does too. So if I find blocks here, then I start to suspect that people have blocks in their heart arteries as well. Okay? So we've talked about doing scans, we've talked about looking at risk factors. Now we mentioned earlier one of the big risk factors for heart disease, for stroke, is blood pressure. Blood pressure, cholesterol, we have abilities to monitor your blood pressure over a 24-hour period. You check your blood pressure, you go to the doctor's office, always high. At home, always low. That's something we call white coat hypertension. But sometimes it's not truly that. You may have a problem with your machine at home. So what we do is we put a 24-hour monitor on and monitor over a 24-hour period to ensure that we're not making the wrong diagnosis. If your pressure is high over the 24 hours, we bump up your meds or we start meds if you've not been on it. If you get palpitations or heart beating irregularly, you go and do an ECG, most of the time it's normal, but at home it's palpitating, it's moving fast. We can put a monitor on over a 24-hour period and monitor that to see what's happening. I mentioned that sometimes the pipes get messed up, and other times the electrical activity in the heart gets messed up as well. Okay, so this is what a monitor like that would look. Just sits in your chest and monitors the heart rate. Okay, so these are things that are available. I'm just telling you what the technology is out there, how you can preempt or prevent a problem if you're getting symptoms, because the technology exists for you to do some of these tests, whether in the public sector or in the private sector as well, all available. But the most important test, I think, and unfortunately this one, you may not be covered by your own insurance or by, they can't do it in the polyclinic, but if there's any suspicion of blocks, the quickest, fastest way to find out if you've got a block is to do a CT scan of your heart arteries. You may have to do some of that out of your own pocket, but it's well worth it. Most of us, even myself, have been doing it every few years just to make sure we've got no blocks. A CT scan does involve injection of contrast, X-ray under a CT scan, but it's the simplest, fastest way to figure out if you've got a block. It's actually just a 10-second breath hold if you feel warmth going down your body. And if you look here, you get 3D reconstructed. This is an artery with no block. This is an artery with a block. And you see where the block is? What you see is contrast, or the dye going through, and where it's narrowed is where that block is. So this is where that block is. Can you see that? Everyone can see? Simple. Once you've got a block, depending on how bad the block is, take medication for sure. Whole life, definitely. But fixated needed, ballooning, stenting, there are many methods to do this, and I'll go through that in a short while. Okay. Once again, this is someone else's CT scan. What you see is the contrast of the dye flowing through wherever the artery is. This guy has got multiple blocks here. This is someone where we have to put a stent. The only normal area is here. This is all blocks. We put a stent from here to here and open it all up. Okay? And once you do, what was a 90% block becomes 0% once you do. Okay? So this is the technology that we have. This is a CT scan. Just showing you the different pictures. Now you hear of all kinds of other scans, nuclear scans, PET scans. I'm just putting this in because your doctor may advise some of these tests depending on what you need to do. Some of these involve injecting a radioactive isotope, a radioactive substance, and looking to see where it sits in the muscle and whether that area of the muscle has a lack of blood flow. So these are all tests that exist, okay, just to show you, right? And the most important thing is most people, when they go online, say, oh, the radiation is very, very high. The radiation dose of a CT scan is very, very low. This is a radiation chart of angiogram, some other tests, CT scans. With a low dose CT scan, radiation is very low. And in fact, it is the difference between living in Singapore and Beijing for 3 months. That's the only difference. Or about 3 transatlantic flights. You fly to the US and back 2 or 3 times, that's 1 CT scan. So the radiation dose is very, very low. Don't be too worried about it. Okay? So, we've talked about diagnosing, how to find blocks, how to figure out if you've got abnormal heart rhythm, how to detect blood pressure. We've got state-of-the-art treatments as well for all this. There's a lot of new technology. We live in a fantastic age where there's so many new innovations, especially in cardiology. Every week we find something new. Yeah? So what are the state-of-the-art treatments? Of course, you need to do an angiogram. You've all heard of doing an angiogram, angioplasty, ballooning, stenting. Yeah? So an angiogram is done like this. We inject contrast directly to look at the heart arteries and supply the heart muscle. Okay? This is more or less the setup for it. I kind of stand here while I pass the catheter. The patient's usually over there. We look at the monitor. It's like playing a video game because we're doing stuff here. We're looking at the screen there. And we wire the wires to it. I'm going to show you how we do that. Okay? Most of the time nowadays, the last 15 years, 20 years for myself anyway, I've been going through the arm. You've all heard of people doing angios through the leg, but a lot of it nowadays is through the arm because you can get up and you can walk almost immediately after the procedure. You pass the catheter up the arm, inject contrast in, and then decide what to do. So this is how we do it, okay? This is the arm. If you all don't mind, if you just feel your pulse. Do you know where to feel your pulse in your arm? Most people will be able to feel it right here. Okay? Yeah, actually, everyone actually knows where to do this. Okay, so this is great, right? And that is, you pass a 2mm tube up that, right through, and we know which way the arteries go. We pass a wire, pass a tube over it, sit it in the heart area here, inject contrast in. So that's the route that we go up. In the old days, everybody used to do it through the legs. 99% of the time now, we can do it via the radial artery, which is here. Yeah? Pass the catheter in. This catheter, this tube is 2mm thick. It is tiny. Okay? So when we pull it out, there's no scar, no nothing in the arm. We inject the contrast. That's how the tube goes in. Someone like me has to push it though. Okay, it doesn't go in on its own. We inject it, inject contrast, and this guy has got a block here. When there's a block there, what do? We put another tube through, put a wire through that, balloon it, stent it, and then we're fixed. It sounds a lot easier than it really is, but so this is what a catheter looks like that we pass through. Inject contrast in. This guy's got a block here. A blockage in the heart artery. Can you all see? Where you see is where the contrast goes through. The contrast is a dye that fills the artery. Where it's narrowed, it becomes just a little string of flow through. So what we do is open that up. So I told you we're plumbers, right? So we do plumb. We open it up. Okay, and this is how angioplasty is done. Okay, so the old way was, of course, going through the legs. See, so nowadays you don't have to lie still. How many of you know of somebody, I'm not saying yourselves, who's had to do it through the leg and had to lie down straight the whole time? Many people, right? Many. How many of you know people who've done it through the arm? Also, okay. Less, because in the old days, everybody did it through the leg. And it's so much easier now. We pass the catheter through, inject contrast. It's a lot easier, the new route is better, right? So technology moves on. For the last 15, 20 years, we've been doing it through the arm. You'd be surprised, in the US, they only started doing it through the arm 5 to 7 years ago. The Japanese pioneered it, the Europeans, then us in Singapore as well, and only now in the US. There are special balloons that we use in Singapore for the last 15 years. They're just starting to use it in the US. So you actually live in a place where a lot of new technology comes through, because in the US, it has to start from the US for them to adopt it. In other parts like Singapore, we take the best from Japan, from Europe, from Korea, from Singapore itself. We have our own stents in Singapore as well. Okay, so this is what a heart attack artery looks like. Contrast, no flow. Balloon going through, right? We pass the balloon, it's like a railroad right through. And then we open it up. But if you look here, it is still looking, this part is big, this part is big, this is still a bit narrow. We put a stent here to hold it open. That's what the stent is needed for. The stent is a scaffold to hold the artery open. So these are the different steps. For those of you, because many of you are looking at the age group here, you will either have had some of this done, or you will have family members who are having some of this done, or friends. So these are the steps. There's a block, you balloon it open, you re-establish flow, it usually recoils because it squeezes back. Then we put a stent inside, over another balloon, pop it open, and you remove the balloon. So a lot of people say, ballooning, I've got a balloon inside. The balloon is always removed, okay? There's no balloon inside, okay? There's a stent inside. Because if the balloon was inside, it would still be occluding the artery. So I've got people coming and say, I've got 4 balloons inside. I said, the balloons are still there, can you take it out? Okay? The balloons have already been removed, okay? So don't worry, all right? Right, and that's what it looks like, okay? And that, on the right-hand side, actually, you see someone's finger, the size of the stent. It is tiny, okay? 2 millimeters, 3 millimeters, max 4 millimeters, most of the time. Now, for those of us, and I probably send about 1 patient a year for bypass surgery, because the technology is so that we can do ballooning and stenting for most people. For most of the time, we can manage with minimally invasive techniques. But bypass surgery or open heart surgery, that also exists, right? And for a minority of people where the blocks are so bad, too many blocks, very, very difficult to fix all the arteries in one go. You go through bypass surgery where you take a vein or an artery from the arm or the leg, stick it across, and you bypass the block. You don't remove the block, okay? But it bypasses it, that block. Stick it on, you've got a new vessel, the old block still remains, no one scrapes it out, okay? But these can also reblock over time. 10 to 20% chance that you can get a reblockage within any of these, same way you can get a reblockage within the stent. But at the same time, you can get reblockages within other areas as well. You got 20%, 30% block, that can progress as well. All blocks increase in size. If you take your medicines, you manage the risk factors, the chances of it reblocking are less than 10%. The chances of an old block becoming big enough to give you a heart attack over your lifetime is less than 10% as well. But that's why the medicine is very important. And a lot of the time, the medicine is what people forget. Because they feel well, they don't do anything, bypass surgery done, got a scar, everything fixed, and well, they stop all their meds. And that's when people start getting new heart attacks, new problems, new balloons, new stents. Okay? So, once again, I mentioned that we live in a very, very modern age, advanced age. We've got a lot of cool new technology, especially here in Singapore. We have a lot of stuff, people travel from different parts of the world to come here to get their stuff done, because we have this kind of capacity here in Singapore. So we have new technologies. When we do ballooning and stenting, we don't just pass a wire inside, we use special imaging to have a look at it. So what you see here is, you all know Mona Lisa, yes? Okay, so we got a Mona Lisa analogy. Mona Lisa not so clear, Mona Lisa more clear, okay? CT scans, fantastic, great technology, but you've got your chest wall in the way, you cannot see it so clear. Mona Lisa is not so clear, you got a block here, you decide to do an angiogram, okay? The angiogram that I showed you where we pass the catheter up, it is more clear. But once we've done that, and we want to look at the inside of the artery, we use ultrasound on the inside of the artery. This is the wire that we put in. We put a catheter in, we look at the wall of it, look to see where the plaques are, where the blocks are, look to see if we put a stent properly, and if we do use these techniques, this technology, the risk of a reblock over your lifetime is probably less than 10%. Meaning, you're 40 years old, you've had your stent, 10% chance of your lifetime you'll never get a block within that area again. Because we use these cool new technologies to fix it. And then we can do it in color. This is Mona Lisa in color. With special light rays to look at the walls. So what we do here, this is the artery, this is contrast going through. This is actually a cross-section cut through, okay? You cross-section cut to look at the artery with ultrasound and with light. So these are the things that we can do to ensure that we get very good results. Now, in the old days, if you had big blocks, all we did was, okay, very, very bad, a lot of calcium, cannot put balloon through, send you for bypass surgery. Now we have better technology. We can drill through the calcified hard blocks. All blocks harden and calcify over time. The older, the longer you have the block, the harder it is to fix, because the harder it becomes. It is like you throw plasticine down the pipe, after a while you put a whole load of stuff in, it hardens, it sticks to the wall. You cannot balloon it open very easily. But if there's a lot of calcium and it's difficult to fix, we can drill through it with certain drills. But calcium is always a difficult one to fix. But now we have special balloons that can crack the calcium. Okay, so this, everyone here has probably heard about kidney stones, gallstones being burst, being hit with lithotripsy, shockwave. We can now do that for the heart arteries with calcium as well. The last 5 years perhaps we've had this. In the last 2 years we've been using it a lot more. We use the same technology, okay, to kind of burst or to shatter stones, to shatter the calcium in the heart arteries. This is a shockwave balloon, okay, shockwave technology. This is how it's done. We pass a balloon in, there are these very cool looking emitters, okay, that send shockwaves out. Very high pressure just to crack the calcium. So I mentioned calcium being an issue. When you have soft cholesterol plaque as it ages and you do a CT scan, the calcium score tends to go up because the body sticks calcium on it to heal itself. But after a while, that calcium is difficult to crack. So with these types of technology, what we do is we send shock waves out. You will see the shock waves being sent out, and you will see that white stuff at the side. Okay? You will see that it starts to shatter, becomes smaller, becomes sandy, and we can push it all the way out. And then we don't need to send the patient for bypass, we don't need to drill through, we can just keep cracking these small, small bits. So this is an artery, that's a balloon, that's the wire over which the balloon is put. These are all the little bits of rock or calcium that get cracked. Okay, I'm just going to ask, apart from the doctors in the group here, has anyone here seen this before? No? Okay, good. So I've shown you something new. Okay? This is stuff that we have, that is available, and we can fix it, and afterwards we put balloons in there to open it up further, and we stent it and fix it, and the patient doesn't need to go for bypass surgery. Okay? Lithotripsy for the heart. Now, we have other devices as well. So for patients where they're very high risk, just yesterday I got sent a CD of a patient from another hospital stating that they think he's too high risk for bypass surgery, too high risk for angioplasty. So the CD was sent to us, and it's true. The pump function, remember I told you the heart muscle was very weak? A normal number for a good ejection fraction, the heart pumps out 60% of blood. His is 15%, it is 1/4. So it's high risk. Bypass surgery, they feel that there's not good enough grafts that can go onto it, because the arteries are so badly diseased. And ballooning and stenting, they feel that the risk is too high. But for patients like that, we have special devices now. It's like almost doing a bypass of heart-lung machine while we do the ballooning and stenting. This is called the impellent device. Unfortunately, it is very expensive and very costly to use. But in the old days, the surgeons used to put tubes in there and bypass the flow of the heart while you stop the heart for a while, okay? Now what we can do is put a catheter inside, suck the blood out, and push it forward, so the heart's not moving while we do the ballooning and stenting. So we have technology like this, and this is just coming into Singapore now, but it is a bit pricey, and it is something that we are pushing in our center forward, but not available everywhere else yet. Now, I'm just showing you some cool stuff just for you to know, okay? Now, if you've got blood pressure that's high, and you're on 2 tablets, next thing you know you're on 3 tablets, 4 tablets, 5 tablets. Once you need to have so many tablets and you still can't control it, there is a procedure that we can do to burn the nerves around the kidney arteries, to drop the BP so that the number of tablets you're on reduces, or you can come off it to some degree if you're on 1 or 2 tablets. This is called renal denervation. Renal means kidney, denervation means hitting the nerve. This is a special device that we can use, same as catheter, but this one, usually we go through the leg, up there, touch the nerves around the kidney arteries. There are nerves around the kidney arteries that actually regulate blood pressure. You hit them, you start dropping the blood pressure by 20, 30 millimeters of mercury. You know your blood pressure, you measure 140 over 90. Anything above 140 over 90 is abnormal. You want to get it down to 130 over 80. But there are people walking around with blood pressure for 180 over 110, 180, 200. Despite medical therapy. For patients like that, we can do this, where we pass a catheter and burn the nerves around the kidney artery. Over time, this procedure can bring the blood pressure down. This is how the procedure is done. We pass the catheter up, we put a catheter here, this is the kidney. We use special devices and burn. I told you that we are plumbers. In this respect, when we do this procedure, we're like plumbers who are electricians, because we pass a wire in and we zap and we burn. Bring the blood pressure down for the patient. So these technologies do exist in Singapore, with us here and around the world as well, just to let you know, okay? So I thought I'd just show you a few innovative new cool technologies, things you never would have heard. If you go to any normal cardiology talk, I don't think you would see this. So just something new. If it's too over your head, my apologies. I just thought I'd just try and show you some new stuff. Okay, and we can drop the blood pressure that way. This is one of our patients, where we pass the catheter in and we burn. These are the kidney arteries, by the way. Okay, this is a catheter. This is what a catheter looks like. Kidney artery, catheter, kidney artery. And this patient actually is a 40-something-year-old lady who has super high blood pressure, super high cholesterol, disappeared for many years, didn't want to take medicines, ended up coming back and put a stent in her artery. Then her kidney arteries also started getting blocked. This is actually a kidney artery going towards the kidney. This is the narrowing, the block. This is a narrowing in her artery, and we had to put a stent in and do this procedure. She was on 5 medications with blood pressure of 180. She's now on 2 medications with blood pressure of 130. Because we opened up the artery and we zapped the nerves around that area. She's probably about 45 now. Okay? So, I talked to you about a lot of technology, new technology. I hope everyone's okay, not getting bored. You all okay? Too much intense stuff. I thought I'd show you videos. I hope that's okay. Yeah? Videos are easier for you to look at, okay? So, I was also asked at some point to address the topic of COVID. Yes, Ms. Pramila, who I said, can you talk a little bit about COVID as well? So we'll try and bring some of that in. COVID does affect the heart. Vaccination does reduce the risk. The problem, of course, is that a small proportion of people who get vaccinated do tend to get side effects. And that has been something that we've needed to weigh out as a population, as a country, as a community around the world as well. Because now, if you look at it, COVID has become very simple. It's become like the flu. Nobody bothers about it. If you go back a few years, you remember how everybody was being hospitalized. And that's because there's a vaccination program that's gone out, right? But COVID in itself is much more harmful to the heart if you've not been vaccinated. So this is how COVID affects the heart. I think that it's a little bit small, can't see, no? Okay. So COVID is the heart in the center. It can hit the lungs, okay? It can hit the heart muscle. It can hit the vessels. It can hit the coronary arteries. The plaques cause it to rupture. We were getting people coming in one after another with heart attacks straight after COVID. Loads of them. The lungs white out, having to be intubated. So COVID does affect the heart. Now what we do need to understand, and maybe we can address this in the Q&A later on, is that a small proportion of people who take the vaccine may get some of these symptoms too. And it is 1 in 100,000 usually. And we've realized that after the vaccination, do not stress the heart or the lungs and exercise, and that way you reduce your risk for 2 weeks, okay? But it is 1 in 100,000. But when COVID hits the heart, you get big bad things happening as well. What are the risk factors? Okay, advanced age, heart disease, diabetes, smoking. Generally, if you're not supremely healthy, if you're not very healthy, your risk is higher. If you're very unhealthy, the risk is even higher when you get hit by COVID. And all the more reason to need to be vaccinated as well. Okay, myocarditis, you've heard about that, the heart muscle issues. And the most common thing we see with COVID and also sometimes with the vaccine is people come in with palpitations. Usually these last for a few months and then they go away. Okay? So just something for you all to understand. Okay, I've highlighted what is in this article, Singapore Heart Foundation. We actually were involved with sending out this statement some time ago. Some heart palpitations, some regular heart rhythm, a bit of shortness of breath, that may last for a while, but usually it goes away. Alright? And then I move to my last bit, my most favorite part, myths and misinformation. So everyone want to take a break for a minute first? No? All okay so far? Nobody falling asleep. This is the only audience I've had where no one has fallen asleep during the talk. I've been looking at the back. Everyone is wide awake. Thank you. Thank you. No, I'm only joking. Hopefully nobody falls asleep. Alright? But we covered a few things. Heart disease, how to detect, how to treat, what the new technologies are, a little bit about COVID, some new cool technology that we have that we can use to treat very specific and special conditions that in the past were untreatable. But the most difficult thing to sort out in my practice is patients coming in and telling me, Doc, I heard medicine no good for you. Don't take it. Okay? I heard that it is very, very, very bad if you take cholesterol tablets. I heard it's very bad, if you decide to go into a procedure, bad for you, you must not do it. Okay, I'm not saying everybody needs to do a procedure. For those where it's going to save your life, you're having a heart attack, yes, you need to. For those with big bumps, yes, you need to. Okay? But the biggest problem we have these days, I think, in terms of myths and misinformation is the internet. The internet has got a whole load of information that is not vetted. It is not clarified. You don't need to prove that it's true. You can put any statement out there, and it will sit there if people click on it often enough. So myths and misinformation. So I brought up a few examples. Because just last week, there's a group of patients who have my number, and all of them were sending me this. They said, "Oh, Doc, how come we don't have this in Singapore? Laser to fix blocks of the heart arteries, and they have it in this hospital in India, in Nagpur." Okay? So then I have to start sending out messages telling them that, look, this technology has been around for 20 plus years. We don't use it here in Singapore because actually it doesn't really work that well. But the way things are marketed online is that we have this, you should come to our country and do this because this is so special. What you use is a laser. You've all heard of lasers, right? Everyone knows Star Wars, lightsaber, laser. You laser to cut it. But we don't need to do that because we've got balloons that can do that. We've got shockwave thing that I showed you earlier that can do that. So nobody needs to use this. But what this is a marketing ploy. that's put in, and understandably, because they are promoting their hospital, they have new technology, new stuff, it's perfectly okay. But this is just one example. There are many such examples where things like this get put out and you receive it on your WhatsApp. So what I'm trying to tell all of you is please take it with a pinch of salt. A lot of the stuff that you see on WhatsApp, a lot of the stuff that's pushed out on the internet is not necessarily true because there's no way to verify it. Okay? This is one of them. I'm going to show you some other stuff. This is even better. Okay? Attached to it is a note saying no need to do ballooning and stenting anymore. Now all you need to do is use this device to suck out your blocks. Now if you think about it theoretically, that's the dramatic music that goes with it as well. Okay? You can hear it in the background. But quite cool, right? So everyone gets very impressed. But you can't suck out a block. You can suck out a clot. A clot is where a plaque ruptures and it's soft. When you've got a concrete hard block, you can't suck it out. This device was marketed in 2005. It has now been almost 20 years. The same WhatsApp message goes out every year or two, saying you don't need to do balloons or stents anymore. You can use this and suck out all your blocks. And if it was so true, it would have been proven true by now, 20 years later, and it hasn't. We've been using this kind of technology to pull out clots if people get heart attacks. I do acute calls for Toxic Hospital, where people have heart attacks about once a month. I do a call for them, not very often. And we suck out the clot, we put in a stent, and fix it subsequently. But what you have is dramatic music, stuff like this online telling you you can do this, and then they'll link it to some hospital somewhere, saying go and see them there. And usually even that hospital doesn't know their name has been put into it. Okay, so I'm just showing you how they do this. So this is 20 years old. Has anyone here received this video? Okay, you have. A few times by now. Every few years it comes. Because we probably have the same social circle. You know, my dad said it. You said it to my dad.
No, the reason why I said it is because a lot of fake news in the literature, not only, they send one by one, and then one particular individual say, we are the best in the world, we do. Don't believe it. Just a fake news. So consult a cardiologist, then you will know what is correct.
Thanks. So we see this, because if you move in the same circles, you receive this. Now that is not as bad. It's just only used to remove clots and stent. We've been doing this for years on it, and that technology is too cumbersome. It actually causes problems, and it was stopped. But it still circulates every few years. Now, if you think that one's bad, this one's even better. I don't know if anyone's received this.
Machines work. The device is introduced into the human body
using nanobots to fix your heart arteries. Anyone receive this?
The affected area.
You have.
Built-in mini camera makes it possible to control the entire course of the process.
I'm just going to let it play for a bit to show you how dramatic it is. Okay, it's not true, first of all, and I'm not promoting this technology, it's not true.
Tanks that prevent blood flow. If necessary, blood is pumped off and the area is filled with a transparent compound. The cholesterol is removed using a patented plate cutting tool.
So if you think about it, it's not possible. We don't have machines like this.
Based on the firmness
It's not possible.
the thickness of the artery, the location of the affected area.
So I've got people asking me if we can do this. Has this already come to Singapore?
Cholesterol deposits and is guaranteed to leave the arterial walls untouched.
And very dramatic music that goes with it as well.
Sucked out of the blockage area. The clamps and tanks are removed, and a flow of fresh blood is provided. The artery has.
I'm just going to move on from that. Okay, when you received this man, did you think it was believable?
No, I sent it forward to one of my doctors to verify.
Yes.
And the answer came back is just rubbish.
Yes. You know, and understandably, because you're smart enough to go and do that, but some people may think, God, maybe this exists, we live in such a great age, there's a lot of stuff on TV, but this kind of stuff doesn't exist. So there's a lot of fake stuff that goes out there. Now, some people may not agree with this slide, okay? Because on the internet as well, it is repeatedly marketed. Don't take tablets, instead go garlic, omega, ginger teas, and all your cholesterol issues will be sorted out. I have so many patients that I told them, okay, you try, come back and you check your bloods 3 months later, there is no difference. What does make a difference is the lifestyle change. So when you decide to do all this, and you make a lifestyle change with your diet, your exercise, cut down the fatty food, replace the unhealthy food with healthier stuff, then your cholesterol does come down. So studies have shown ginger, garlic, and all that does not reduce your cholesterol. Garlic, there's been one study that shows a 1% reduction. A 1% reduction. Yes, sir?
Dinesh, are you saying omega, fish oil?
Perfect. Fantastic question. I'm going to answer that right now. Okay. Omega does not reduce heart attack risk. It doesn't. What omega does is reduce your triglycerides and slightly raise your HDL. If you take omega, rich and the pure omega stuff that is pharmaceutical grade, which is not what most of you will get, you'll get a better result as well. But what does omega-3 fatty acids do? It reduces triglycerides. It can raise your HDL a bit. But the HDL studies that have been done have shown that increasing your HDL by any means does not reduce your heart attack risk. HDL is your baseline risk. HDL or good cholesterol. So if you've got a higher HDL, your general risk is lower. You bump up your HDL, even if you double it, you don't reduce your risk. That's what the studies have shown. If you drop your triglycerides, you reduce your cardiac risk minimally, because triglycerides are not what causes the cholesterol deposits in the heart arteries, unless you have triglycerides that are in the thousands of super high. So there are many patients who take omega, thinking that they're going to reduce their heart attack risk. If you look at the literature online, all the studies have been negative except for one. And that was a pharmaceutical grade omega that was produced by a certain company. And what they found was that that particular omega had antiplatelet activity, which is why aspirin reduces your risk to 10 to 20%. So omega does not reduce your LDL. It has zero effect on LDL or the bad cholesterol. Now, many of you may have watched a program on Netflix called The Game Changers. Has anyone watched The Game Changers? It was about a bunch of firemen who decided to diet and exercise, reduce their cholesterol, reduce their risk. But what happens when they do take things like omega-3 fatty acids and they diet and exercise? You get a 10% reduction in your LDL, but you can get a 50% reduction in your triglycerides. Your total cholesterol is all those combined into a formula for your total cholesterol. So if you drop your total cholesterol a lot, most of it through lifestyle changes is through triglycerides being dropped and not the LDL. And therefore that risk reduction is not the same. If you have blocks identified, the only thing proven at the moment to reduce that risk is to go on a certain group of drugs called statins. There's also other drugs that I can talk about, such as ezetimibe, which blocks cholesterol dropping. You've got some injectable medications that drop your LDL 50%. Those are the only ones that have been proven. And omega does not reduce your cardiovascular risk, because all the studies done subsequently don't show that. I don't know if you know about this, but there's so many published in the cardiac journals now that have proven that omega doesn't make any difference, except for that one study that showed it with a special pharmaceutical grade omega. And because of that, people are selling omega online and telling them, don't take your cholesterol tablets or your statins, but take omega instead. Ginger and teas, I think all this is good. And you know why this works to reduce your cholesterol a little bit? It's not that particular thing. It's because you've gone into a healthier lifestyle, replace the unhealthy stuff with the healthy stuff, and you reduce that risk that way. We can address this again so later on if you want. Okay? And this is one of the last few slides I'm just going to show you. How many have received this? Good news, Lipitor users rejoice. This is now off the naughty list. Cholesterol is no longer deemed a bad substance. The date of this is 2010. Ever since 2010, this thing every year or two is being recirculated. And patients come off cholesterol meds as a result, thinking that they don't need to do this, because now in the US, everybody believes this. First of all, nobody in the US believes this. Secondly, this is from a very dubious publication, and this is in 2010. The number of patients, does anyone receive this? No, maybe not this group. It depends on which WhatsApp group you're on, what you receive, okay? So this, in itself as well, is not entirely true, okay? So these are all the slides to show you stuff. I hope I've not bored you too much. I'm going to end with just one case study, if that's all right, a patient of mine that I just did angioplasty for recently. Okay? Now, if you look at his profile, okay, he's fit. You can see the abs. Okay? You can see his abs. All right, that means he's super, super fit. 52-year-old guy, Chinese, slightly younger than me. BMI 19, super slim. Okay? Ex-smoker. That was one of his risk factors. Does Qigong regularly. Qigong practitioner for the last 10 years. Okay? So very fit. We went in. Remember that sign around the eye that I told you? That was the first sign that something is not right. Okay, he's got a rim of white around his eye. No one ever noticed it. They all just thought he looked cool. Right? Soft murmur that I heard, no issue. Not keen on medicines. His LDL, okay, total cholesterol, I showed you the numbers. 200 and above is considered abnormal. LDL above 130 is abnormal. His LDL has been 200 for 10 years. 10 years, 200. Okay? And he's been taking supplements like garlic, omega, all that stuff. His LDL never budges, but his triglycerides come down every once in a while when he takes the omega. He's also dabbled with something else called red yeast rice. Has anyone heard about red yeast rice? Anyone? Yes, lots of people, I'm sure. Red yeast rice is basically what the statins were made from to start with many years ago. Lovastatin, if you have been to the polyclinics 20, 30 years ago, that was the initial statin that people gave, lovastatin. Lovastatin was derived from red yeast rice and taken out and purified to create that. We have newer statins called simvastatin, atorvastatin, rosuvastatin. You've heard of these names. They're all called statins. They're cholesterol tablets that reduce your heart attack risk, drop your LDL 50%. So red yeast rice has a little bit. It's like taking 1 milligram of lovastatin. So therefore, it doesn't budge the cholesterol that much. And it's sold over the counter, so people buy it thinking it's natural, right? So he's been taking a number of these things. He's got a few other issues that happen with high cholesterol. Okay, bit of fatty liver, gallstones. All these happen because of high circulating fats depositing wherever they need to. High circulating cholesterol. So this guy is super fit. Okay, does Qigong. This is his CT scan. So I did his ultrasounds, not much. His echo pump function, okay. This is his CT scan. Contrast going through, almost no flow here, coming out. There's a big gap here, okay. This guy didn't know anything about his blocks. Because he was doing Qigong, he managed to overcome the blocks. But the blocks don't go away. And he's actually hanging on a thread. At any point in time, if this closes off, it's a massive heart attack. So that's what this guy had. What you see here is, I said target LDL for people who've got big blocks. The LDL should be less than 55. I mentioned that 100, 130. I told you that if you, when you were a child or if you were an animal in the wild, your LDL is less than 50. And this is what's been derived as the target for those who have big blocks in their heart arteries. So he started at 200. Took a bit of red yeast rice, exercise, got it down to about 170, 180 for many, many years, and didn't move. When we put him on medication, we dropped his LDL. This is a chart. 1,500, 150, 200, 250. From 200 to 100 plus, and all the way down to about 50 with the medication. So now his risk is low. Once we've done that, that was around the time when we had to fix his heart arteries. So I'm going to show you what an angiogram looks like of somebody with a very big block. What you see is contrast going through the arteries. There's so many arteries, so it looks very confusing. That's why we put a still picture here. If you go down here, this artery should be coming down all the way there. It's missing. And he's got a big 90% block here, and down here there's no flow. What you see going down here is where that artery should go. So he was very lucky. It just happened, and it's strange enough, I had just given a talk at a public forum, actually organized by a Buddhist association. So he follows this particular Rinpoche, who's a teacher, right? So they invited me to give a talk. And the next day, the wife brings him along. Of course, the wife is worried about him and not about herself, right? Please check my husband. And we find out these issues. We do a CT scan, we find this is what we have is a block. We do an angiogram soon afterwards. There's no flow. And I'm going to show you. If you look at this picture, you identify that there's no artery going down here. I don't know if everyone can see this. And this is what it looks like afterwards. This is that artery that was practically missing the flow. We ballooned, we stent. This took a long time. It's 99% blocked. We have to find a way through with the wires, and it's all opened up. So this is what it looks like after we fix. You see this, yeah? Somebody just follow my red line here. And what it looked like before we fixed it, because there's no, there's no flow here. I'm just showing you this because this just happened last week. Okay? Lots of people, very fit, who don't know what's going on with them, think they're okay. These are the guys who then go and run a marathon or something like that and collapse without knowing. 50% of people who've got blocks in their heart arteries don't know they have one until they have symptoms. Okay? Is this clear? Can everyone see? I'm sorry, I can explain again. Anyone not clear about this? Where this artery is completely, almost missing. Okay? So this is what we see, and this is why it is important to catch a heart attack before it catches you. Yeah? Thank you.